First, the unofficial part. I'm very glad to see you all and to join with you the 27th Alzheimer Europe Conference. Now the official part. Ladies and gentlemen, dear representatives of Alzheimer societies, I want to share with you reflections about home care and dementia, relief for caregivers and support for care receivers. The next slide, please. The person with dementia and his/her needs should be at the center of any support provided. This is a general recommendation. For the realization of this motto, we have to act in concert. Next, please. During the past decades, we have established a broad spectrum of services for persons with dementia and their caregivers. These interventions have different focuses. Either they address caregivers as psychoeducative interventions, or they address persons with dementia as support groups. Again, several other services are either support or therapy for care receivers or respite for caregivers, as day hospitals or short-term residential care. Daycare, in the center of the slide, is a service with benefits either for persons with dementia or for their caregivers. What do we know about the impact, or more precisely about the effectiveness of these services? Next, please. Focusing on intervention studies on highest evidence level, such as randomized controlled trials, we can see the following findings based on the meta-analysis of Sørensen and colleagues. Psychoeducation, supportive interventions, and psychotherapy show significant effects on caregiver burden. You see this on the left side. Depressiveness and caregivers' ability and knowledge. But on the right side, but not on the care recipient symptoms. Unfortunately, there is no updated meta-analysis. Next, please. The current systematic review of Thoms and colleagues is citing only one RCT on support groups for care receivers. They refer significant effects on mood and quality of life of persons with dementia. Next, please. Similar poor is the evidence for respite services for caregivers of people with dementia. There are no RCTs on respite or adult daycare, and no controlled study on in-home respite, according to the current systematic review of Van de Pitte and colleagues. Thus, we know little about the effectiveness of these important services. Therefore, we need more studies with elaborated methods. We need more substantial results for successful negotiations with our health insurance and our long-term care insurance to improve the financing of these support services. For all professionals who are in contact with family caregivers, it is very obvious that there is an urgent need for respite offers for caregivers. What do we know about the utilization of respite services? Next, please. It makes me think when I see the statistics of utilization. They range from 6% for out-home respite to 19% for in-home respite. Perhaps the utilization increased slightly during the last decade, but there's no relevant current data. Next, please. In contrast to the low utilization of respite services, subjective burden for caregivers of persons with dementia is comparatively high. 62% of family caregivers in Germany feel severely to very severely burdened. For these caregivers, the risk for physical, psychosomatic complaints is much increased. This demonstrates a current cross-sectional study in Bavaria. However, there are possibilities to improve this unfavorable situation. Next, please. In our current study, which was granted by the Spitzenverband der gesetzlichen Krankenversicherung in Deutschland, we combined a psychosocial intervention for caregivers with a multi-component non-drug therapy for persons with dementia called MAKS. First, a brief telephone counseling with 3 calls within 6 months was focused on the development of strategies for self-management and of techniques to deal with challenging behaviors. Secondly, simultaneously, the MAKS therapy was established in 16 daycare centers distributed all over Germany. MAKS consists of 4 components: motor stimulation, activities of daily living, and cognitive stimulation in a social setting which can be performed according to a manual. Next, please. Here are our first results in a few words. Cognitive abilities and abilities of daily living of persons with dementia remained on average at the same level. You see the blue line. They decreased significantly in the control group, green line. However, not as seriously as under completely untreated conditions, red line. Next, please. The caregivers benefited from combined interventions too. Depressiveness and subjective burden decreased in caregivers of people with mild cognitive impairment or mild dementia, while no benefit could be achieved for caregivers of people with moderate dementia. You see on this slide the difference between the intervention group and the control group. Next slide. For example, telephone counseling for caregivers. The caregivers benefited from the combined intervention too. For example, telephone counseling for caregivers of the MAKS therapy for persons with dementia can easily be implemented, but it has shown that there's a gap between need. You remember 62% of the caregivers had severe to very severe burden, and the utilization of respite offers, only 6 to 18%. We have to motivate caregivers and their involved relatives to make use of beneficial services. Next, please. What did we learn and what can we do? Next, there's existing a wide range of different support services and relief offers. But, however, there is a lack of utilization. Next, we have to optimize the quality and the related effectiveness. And C, the availability, especially in rural areas, and the ability to finance these support services for the involved persons are to be further improved. D, the common knowledge of support services and relief offers and the willingness to use have to be boosted. And now my last slide. Let us act in concert. Positive emotions of helpers and help receivers will strengthen each other. Thank you very much for your attention.